All right, well, good morning. Welcome everybody to Pediatric Rounds today. We're very honored to have Dr. Norman Silverman to present the Department of Pediatrics Rounds. And Dr. Silverman is Professor Emeritus in the Division of Pediatric Cardiology at the University of California, San Francisco, UCSF. Also Professor Emeritus at Stanford University and Honorary Professor of Pediatrics at the University of Cape Town. He's a true pioneer and a world expert on pediatric echocardiography, having started the career in cardiac ultrasound in 1972 and had the original work at UCSF that established echocardiography as the preferred diagnostic tool in pediatric cardiology. In the old days, patients had to have cardiac catheterization prior to surgery to figure out what was going on. And as an outstanding imager, he contributed to major landmark papers that impacted how we would take care of pediatric patients with congenital heart disease thereafter for the many decades to come. He's an avid educator, having lectured extensively, trained hundreds and hundreds of physicians, and impacted the career of so many. I had the bad idea of printing his curriculum vitae and realized that I was killing many trees doing that. He has almost 300 peer-reviewed publications, major reference textbooks under his name, landmark training text for pediatric echocardiography and several others, an extensive list of honors and recognitions, like the Founders Award of Lifetime Achievement in Echocardiography for Pediatrics and Congenital Heart Disease in 2000 by ACE, Excellence in Teaching in Pediatrics Award by ACE in 2008. He was past president of the Society of Pediatric Cardiography, and a long list of contributions to service in various prestigious societies. And then over the past 4 decades, he really built a national and international reputation centered in teaching and mentoring as well, and continuing to contribute an innovative techniques and diagnoses. So he's one of the worldwide leaders who advanced the development of 2D echo and fetal echocardiography. Even as emeritus professor, he continues to be very active and contribute to our field in so many ways, and demonstrates his commitment today, getting up at 4 a.m. in San Francisco to present to us Pediatric Rounds. So welcome, Dr. Silverman. It's such a pleasure to have you.
Thank you very much, Jackie, for that wonderful introduction. I'm almost amazed at that person because it doesn't seem to be me. But anyway, thank you so much for that introduction. I'm going to begin my presentation now by saying, firstly, that it's a great pleasure and honor for me to be back, even virtually in Pittsburgh. I spent many summers in Pittsburgh with Dr. Zuba Buehler and Dr. Bill Netches and your wonderful pathology collection in Pittsburgh on several summers in Pittsburgh. So I'm really quite familiar with Pittsburgh and have a great affection for the place. So we're going to talk today about the history of echocardiography. I'm sharing my screen with you now. And as you've said, this is the new UCSF Benioff Children's Hospital in downtown.
Dr. Silverman, your screen's not populating.
I don't understand why. Let me try. Let me just get into share screen. That's why. How about this? Now?
Yes, we're seeing.
There we go.
Yeah.
All right. So this is the UCSF Benioff Hospital, and this is Stanford campus, the quadrangle. And here is the University of California of Cape Town underneath the Table Mountain. So those are the three places I've worked in the last 40 years. So I wanted to begin this by actually bringing to a group of pediatricians the relevance of knowing something about ultrasound. And the relevance is, I've just spoke to Dr. Zuckerbrand now about POCUS, which stands for the point of care ultrasound. And this is a very important topic because we've taken ultrasound out of the hands of a special few and placed it in the hands of pediatricians and other physicians at the point of giving care of cardiac ultrasound. And I think that as this has become so relevant, that it's important that we know something of the history of the development of ultrasound in general, the trials and tribulations. And so there are 10 most important pediatric point of care ultrasound emergency medicine issues. First, you can see young hearts and focus on the cardiac nature of cardiac complaints in emergency rooms. There's this called RUSH, the rapid ultrasound for shock and hypertension, where you can look at cardiac performance and see whether it is a contributor or a bystander. We can use the ultrasound to vascular access to make that easier, and also for nerve blocks as a safe alternative to opiates for minor procedures. You can diagnose pneumonias and pleural effusions with ultrasound. It is the standard of diagnostic imaging for interception, improves the soft tissue management of infections, important for looking at hip pain and treating hip pain in children, and near perfect accuracy for detecting pyloric stenosis, and accelerating the diagnosis of pneumothorax and helping guiding treatment. So here is a couple of interesting issues. We're looking at the right at a normal hip, and at the left at a hip which has clearly got a space between the hip and the socket related to an effusion. Now, when we look at an interception, you can see the interceptum in the intercipiens, and here it runs here, and down below we see the same thing as well. And this, of course, is now easily treated non-invasively as well. Now, we're going to focus on the history of ultrasound, and of course, I could give you a boring verbal lecture about all of these issues, but I'm an imager and I'm very interested in images. And so I'll give you another image here. And this is an image by Diego Rivera, who was the husband of Frida Kahlo. And he was a mural painter as well and painted several murals. This one is in the pathology collection of the New Mexico facility, and is a history of ultrasound of cardiology based by a series of images. And I'm hoping to do the same thing. So, of course, everything needs to be sorted out. This is Michael Servetus. Michael Servetus discovered the pulmonary circulation. He wrote it down, but then appeared in front of a tribunal of religious people in Spain and was burned at the stake. Okay, you have over here Laennec listening to the heart as an auscultation. You've got Andreas Vesalius. Here is Andreas Vesalius, the Belgian person who worked in Padua, showing the dissection of the heart from a corpse. And you have Hippocrates of Kos on this side. Now, on the more modern side, this is an homage to this gentleman who was a great French clinician. But I'll direct your attention over here to another area of cardiology. And this here is Maud Abbott and Rokitansky for their contributions to cardiology and congenital heart disease. Maud Abbott wrote the first volume in 1936 of her Congenital Heart Atlas, which is still available and quite amazing document in and of itself. So perhaps images make the issues more interesting. And here is a zoom which shows Rokitansky over here, Count Rokitansky, a great pathologist, and also had some contribution to the cardiac circulation. And here is Maud Abbott, drawn by him as well. Now, another person that's important in our history is George Santayana. George Santayana said, and this is his direct quote, "Those who do not learn from history are doomed to repeat it." And so, unfortunately, there we go. And we have several points in our journey through the history of ultrasound that brings to mind these various problems. So where did we start? What have we learned? Where are we at present? And where are we going? So where do we start? This is Father Abbe Lazzaro Spallanzani, who lived in the 18th century and is frequently referred to as the father of ultrasound. He was a scientist who observed that bats were blind and in fact navigated by means of echo reflections using inaudible, in fact, high frequency ultrasound, which is ultrasound. And here are these charming little, usually vegetarian or insect eating creatures, mammals, that have got a pretty bad rap from us anyway, but they navigate using a form of ultrasound. The next person in this field is a physicist called Christian Johann Doppler. And Christian Johann Doppler was interested in working out whether the universe was red-shifted or blue-shifted. If it was red-shifted, it was expanding. If it was blue-shifted, it was contracting. And here is our usual, there's the equation which nobody ever seems to be able to remember, described this in 1842, and it says that the change in frequency is proportional to twice the carrier frequency times the velocity times the cosine of the angle of incidence over the connection of the speed of the substance, in his case, the speed of light, in ours, the speed of sound, in terms of working out what is the velocity of the structures in the universe. And he found that the universe is fortunately expanding, so we don't have to worry about being crushed in a ball of fires like the original of the Big Bang. So we've all heard this with the air, the siren is coming towards us, and this of a high frequency, and as we pass it, the frequency changes, and this is called the Doppler shift. And this was developed by Christian Johann Doppler and substantiated by a number of other people using a variety of techniques. But really, ultrasound and imaging started in the 1900s. In 1903, Dr. Marie Curie and Dr. Henry Becquerel received the Nobel Prize for the recognition of X-rays and what X-rays could do to the human body, setting off modern imaging. Now, Marie Skłodowska-Curie also won a second Nobel Prize in 1911 for chemistry, recognizing the substance called polonium. She was married to Pierre Curie, and that's why she had the name Skłodowska-Curie. And Pierre, with his brother Jacques, discovered the piezoelectric effect, which is when you put a signal or an electrical charge on a piece of barium titanite, it vibrates. And this is the origin of the production of ultrasound. So this is really kind of a very important recognition for our talk today, far more important than X-rays, but not more important in terms of its historical importance. Now, in Europe, everybody was related one to the other. And this is John Bernoulli, who lived in the 17th century, and his son Daniel. Daniel was related to Lazzaro Spallanzani, and John Bernoulli was related to Pierre Curie. So a whole series of family issues were involved. We know about Bernoulli and Bernoulli equation, which was devised by Daniel Bernoulli. So now moving on to something more initial, and you'll obviously recognize the Titanic below and a U-boat above. This happens to be a nuclear submarine. But anyway, on these vessels, the importance of sonar is particularly important, and also for other ships to recognize this. And we're all familiar with this from movies of the Second World War, where German torpedo boats were recognized by destroyers and were bombed with the depth charges. The Titanic, however, never had sonar on it, and sonar stands for sound, direction, and range. And it's of ultrasound frequency, and had they had that, they would have recognized they were going smack bang into an iceberg and perhaps avoided it and not created the tragedy and the movie. So the Titanic didn't have sonar, and here again is the man who I'll use in the course of this to show how people poo-pooed developments in the field of ultrasound. So now, some of you may not actually know how ultrasound works. So here's a little cartoon so that I don't leave you. And here is a charge which is going to cause a vibration of this crystal. The crystal sends out a series of waves. Here are two metal plates, one incident to the ultrasound and one at angles. When the sound travels through the medium, it strikes these two plates. The first plate reflects the ultrasound back. The other plate pushes it out in space if it's not incident to the ultrasound. And then when you listen, you will hear that this comes back at a certain period of time. And if we know the velocity of the traveling of the sound through water, which is 1,540 centimeters per second, we can work out how long it takes this echo to return and work out the depth. And I can show you this with a diagram here. Here is an ultrasound transducer or a gunboat with a little fish running below it and swimming past this thing. And as it comes through here with motion, you can see this. Here's the fish as it passes underneath the transducer. And if you make this work with time, it gives you the wavy motion of the fish's movement as it works there. And here is the Schlerens chamber, which is a chamber using polarized light. Here is an ultrasound crystal put in a Schlerens chamber, and this is a piece of tungsten wire. And you can see that ultrasound partially obeys Snell's law of light. It can be transmitted, it can be reflected, and it can be reflected in all directions, and it can also be refracted. So it can be focused. So you could focus the ultrasound where you want to do your examinations. Now, the first people to actually do a work with cardiologists. And so I think that it's important that this discipline really started with cardiac ultrasound. And on the left is Carl Helmut Hertz, who is the grandson of the man who described megahertz and kilohertz. And he is a German guy and worked also as a consultant for Siemens in Germany after the World War. And this was a ultrasound structure that was used for detecting flaws in metals and modified for looking at what happens in the heart. And here is a camera which Hertz is holding over an oscilloscope screen. And this is Dr. Inge Edler, the father of echocardiography, who is showing us how this structure works over here. And he looked at a series of pictures like this and said, oh, this is the pericardium. And what happened was the patient that he did this on subsequently died, and he had an autopsy on this patient, and he plunged an ice pick along the direction that he placed the probe and found that, in fact, what he thought was the pericardium was indeed the anterior mitral valve leaflet. Here's the posterior mitral valve leaflet. This is right ventricle, interventricular septum, and left ventricular posterior wall. So what happened here? Hertz told Siemens that there was no future in this ultrasound technology at all. Edler went on and worked on this and pioneered this and made this a development. And so if it had been up to Hertz, we would have had Dr. Santillana again showing us the utility of ultrasound. Now, this is a historical picture. I won't go through this in any detail. It's the same instrument. You notice that the Polaroid camera is supported by a 4x4, not very technically adequate. And here is the heart with the ultrasound being passed through it. And ultrasound, as Dr. Hertz had shown, was a series of spikes which were converted to a series of brightness, B mode. This is amplitude mode. And these dots were then represented as in time as for an ECG, and made sure that you could see the right ventricle thickening and thinning, the septum moving, thickening and thinning, the mitral valve as it opens and closes, and the left ventricle in diastole and systole. So that provided us with originally some very important issues. Now, this is the historical picture. The last time you'll ever see a nurse doing this, handing the doctor a transducer and then providing him with the ultrasound jelly. This is really historical picture. You'll never see that again. So here is the doctor on this patient, a volunteer, I assume. And you'll see again, as we zoom in on this, the feature of resignation on the face of the examinee. And here is the original picture that Dr. Hertz said would be of no future. So anyway, that's the signal plunged through the mitral valve, showing us exactly the line, and was the first way in which we were able to look at ultrasound. And I think that it's important that this was a cardiac development, because the radiologists were offered this technique. And of course, what they said, let me just stop that for a second. What they said, of course, was that, well, you need an ECG to make an interpretation. Let's give this to the cardiologists. And that's why today our cardiac ultrasound called echocardiography is in this area. And the word echocardiography was defined by this guy, Bernie Siegel, in 1969, and he called it echocardiography, which is a lot easier to say than ultrasound cardiography. Now, who was the first person to do ultrasound? And we thought that this was, of course, brought to America, and that was the case. We've seen already Edler did this, but actually the first person to use this was a Chinese man called Xian, and this was described by Dr. Wang, who showed that even the Chinese had got the ability to use a sophisticated oscilloscope with ultrasound on it to provide images of the heart. But in America, it was brought to us by Dr. Harvey Feigenbaum, who in 1963 got an instrument developed by Smith, Klein, and French, and was able to notice a normal mitral valve, an abnormal mitral valve, and published his first paper on a dog experiment where he placed fluid in the pericardium and showed that the pericardium separated from the epicardium proportional to the amount of fluid that was placed in the pericardium. So that was published in 1977. Now, this became quite sophisticated. This is a patient with mitral stenosis. Here is an electrocardiogram. So we know this is systole and this is diastole. Here is the first heart sound and the second heart sound, and an opening snap related to the fact that this was mitral stenosis, and the posterior and anterior leaflets are not moving very well, and the velocity is very low. And you can see the opening snap coincides with the opening of the mitral valve, defining the cause of the snap related to this stretch that occurs in the cardiohemic system. And this was done by Dr. Ernest Craig, who had a technician who was called Roberta Williams, and Roberta Williams has retired now as the chief of pediatrics at the CHLA, Children's Hospital of Los Angeles, and has had an illustrious career as leaders at many, many universities, and is a great ultrasonographer in her own rights. Now I'll move on to 1955, where we have this famous story of one man's signal being another man's noise. And Dr. Shigo Satomura found that there was a lot of noise in blood vessels, that he couldn't work out what it was. And then he worked out through a series of experiments that this was actually ultrasound bouncing off the red cells in the circulation. And he wrote a thesis and developed the first flow meter. Unfortunately, and presented this for his PhD. Unfortunately, he died before his presentation, and Dr. Yasuharu Nimura from Osaka University presented his thesis and accepted his PhD posthumously for him. Now we'll move to Australia, where the Australians started looking at some of the deficiencies of ultrasound in the in the one-dimensional phase, and developed a system of 8 transducers, which were very, very large and were situated in the bottom of a water bath. And here, lying on the table, I'm sorry for the quality of the picture, but this is all I was able to get, shows a woman, a pregnant woman, lying with her belly in this fluid bath. And here is a cartoon of the belly and the fetus, and the ultrasound was making pictures. And this is 1977. And here's a picture of a fetus in its mother's womb, obviously put in the normal position. And here, even with the heart, you could see, here's the fetus's chest wall, here's the right ventricle, here's the aorta, there's the left atrium, here's the mitral valve, and the left ventricle. So, I mean, in a fetus in 1977, it was possible to get beautiful pictures like this. And Dr. Kosseff's instrument was soon superseded by many others. Now we'll talk about pediatrics, and the first handbook was made after Dr. Goldberg had been and working with Dr. Feigenbaum, and you can see here he developed a sweep technique for looking at the heart from the cardiac apex through to there, looking with a one-dimensional system. And this sort of is like a cartoon of this protracted, with the left ventricle here, with the mitral valve here, with the left ventricular outflow tract here, with the aortic valve over here. And we could scan this from the front to the back and from side to side and develop an idea of the heart. And here is the cover picture showing the electrocardiogram, the right ventricular wall, septum, mitral valve, and left ventricle. Now, pretty soon after this, people said, well, one dimensions aren't terribly useful for us. We need to recognize this. And so Dr. Walter Henry, working with the guy called Griffiths, developed at the NIH, modified a toothbrush and put a transducer that vibrated backwards and forwards over 30 degrees in the toothbrush, and provided a picture. And this is the picture of Walter Henry today, but this is his original echocardiogram, showing again the same thing: the septum, anterior mitral, posterior mitral valve, the left ventricular wall, the left atrium, and the aortic valve. And this, of course, moved. Now, I met this man in the late 1970s, and this man's name is Jan Sommer. And he was charged by Philips, the great Dutch engineering company, to make a transducer to look at the brain. And he designed a phased array sector scanner, which is electrically moving the scan. This is the size of 2 refrigerators, by the way. And he produced a picture that looked something like this. We modified 2-dimensional for echo with moving or rotating transducers, or a large transducer with multiple planes in it. And I'll show you all of these in terms of the development of ultrasound. And he presented this, he presented this to Philips, and said, well, they said, there's really no future in this technique. So he published this in the IEEE journal, and it was then became public knowledge. Here is our first foray into this. I've turned this round so that it looks like a heart that we would expect to see. And of course, although you can't really recognize these pictures, they were always accompanied by a diagram, so you could understand what the crazy people that first interpreted these signals were looking at. because resolution was suboptimal. And here is Jan Slummer's original picture of the brain, and you can understand when he looks at the cella turcica that the engineers at Philips were not terribly impressed by this issue. But nonetheless, two American engineers at Duke University, Olaf van Raam and Fred Thurston, worked on this and made a phased array sector scanner. Also working in Holland was this guy whose name was Nicolas Bohm, called Klaus Bohm, and his colleague Charles Lancet, and they were engineers, and they pioneered a large linear array transducer, which I'll show you in subsequent slides. But more importantly than that, they were also able to put an ultrasound transducer on a cardiac catheter. And here's a pencil tip just to show you the size of this. And they were also able to put it on a gastroscope, as you see here, and make an ultrasound that could be placed to look at the heart from the esophagus with transesophageal echo. So these are the guys that actually pioneered this development. Now, my own career came into prominence when we discovered that you don't have to look at the heart on the chest wall, but you can look at it on the apex. And we were able to see, as we looked upside down here, at a heart with the 4 chambers, showing the left ventricle, the right ventricle, the tricuspid and mitral valve moving in real time, the ventricular septum, the interatrial septum, the left and right atriums. And here is a cartoon of this drawing. Again, in the early days, we always used to have a cartoon to show you this because it was hard to see it in real time. And this is from this original publication published in March of 1978 in Circulation. And certainly we were able to then see sizes of the ventricle disparities, ventricular septal defects, Epstein's malformation of the tricuspid valve, atrial communications, complete AV canal, and a variety of other conditions, including chorioatrium, or divided left atrium. So that was the beginning. And we took this picture and we put it on the first book published on 2-dimensional echocardiography. I did this with Rebecca Snyder, great echocardiographer I had the privilege of working with. And in 1982, we published this and showed the heart turned upside down with slightly better imaging here, and how this heart related, in fact, to real imaging. At the same time, Dr. Roberta Williams had a different instrument and was looking at the heart from below. This is a patient that she showed with a tetralogy of Fallot, and you can see left and right atrium. You can see a bit of the right ventricle or the aortic valve here, and a ventricular septal defect looking over that there. Now, we looked at images upside down, and so I'll present to you the lessons we learned from orientation. And those not orienting the images in anatomical or Da Vincian orientation will never decipher the complexities of congenital heart disease. And here's a picture of Leonardo sketched by himself. And this is an inverse of his picture. And if you take the inverse of his picture and you look at the Mona Lisa, you'll see certainly that there's a certain characteristic of the eyes, which is a similar one. And the image that made me change my mind was this one, which was a single ventricle, which we were able to recognize with 2 atrioventricular valves draining into a common chamber. But we called this the outlet chamber. And when we turned this image around so that it looked like a normal heart, we could see that what we called the outlet chamber was actually the inlet to the right ventricle, and the outlet chamber was over here. And since that time, I've never oriented my images in a non-anatomic format. And of course, here's Leonardo's perfect man upside down and also looking at this the right way up. So now to get back to the progress, here is Dr. Son showing the heart in a normal orientation with this linear array transducer. And here is this over here. Dr. Son was a hippie type guy who was often stopped at borders and strip search for illicit drugs, which he never had. Now we look at the next development, which is Doppler ultrasound. And in 1976, Dr. Holen and Liv Hutley from Norway put these gradients and looked for the fact that they could measure the severity of mitral stenosis and very many other images that determined how fast the blood was traveling, the velocity, and consequently to know whether there was obstruction or leakage and so on and so forth. The next device was the use of saline contrast, where agitated saline was injected into an arm, a venous structure, and passed into the heart. And we know that these little saline bubbles, microbubbles or microcavitations, as they are probably better called, are coming to the circulation and are trapped in the lung. And in Rendu-Osler-Weber syndrome, there are multiple pulmonary AV fistulae, that's the disease, and therefore when there's no capillary, the microcavitations go into the left side of the circulation. So here is a picture showing the passage of blood through the right heart and then into the left heart. You'll see it coming into the pulmonary veins and then draining through the mitral valve into the left ventricle, proving that there are obstructions in this area. And this is the old-fashioned M-mode technique, which allows time. Here's 1 second. And you see here is the heart, the blood entering the right ventricle here, and then coming behind the mitral valve over here in about 3.5 seconds, which is about the circulation time. Now, what happened in America at this stage were a variety of people were involved. We'd already seen Roberta Williams and Stan Goldberg, but now Jeff Stevenson was working up in Seattle, and he worked on Doppler ultrasound and color Doppler information. And Dr. Smallhorn and Dr. Stephen Sanders, my 2 great colleagues, worked on echo morphological correlation and really pushed the science. And at the same time, Jim Hooter was talking about fetal cardiac ultrasound in America. And these are really the players. I put my own picture with Becky Snyder in here to show that we were also contributing to this area. And at the same time in London, Dr. Lindsay Allen, Gerlin Charland, and Andrew Cook had last started to look at fetal ultrasound and produced the first color atlas of fetal cardiology. This is Dr. Allen, Dr. Charland. This is Dr. Lisa Hornberger, who was also involved in this project, and Professor Robert Anderson, who put all the morphological correlations together with all of these features. In France, Dr. Fermat in 1985 had a control of almost all of the fetal cardiac exams within the French Republic and was able to look at the 4-chamber evaluation. Dr. Allen taught the screening technique of 4-chamber evaluation in England. And Dr. Kleinman and Dr. Coppell in America did the same thing and showed the success of these techniques. And here's a picture of the late Charlie Kleinman and the picture of him a week before he died. He had cardiomyopathy and a heart transplantation, and he developed hepatic tumors as a consequence of his immunosuppression and passed away. So here's another pioneer of fetal cardiology. Now, you might wonder why I'm showing you a picture of an artist, but this is Dr. Marco Brandestini. And besides being an artist very sensitive to colors, he was also a dress designer. And in his spare time, he was an electrical engineer. And he designed a system of Doppler where he could take the Doppler signal and relate the Doppler velocity to a color. He gave the instrument to Jeff Stevenson, and the Advanced Technology Laboratories built one experimental instrument. And this is the picture of the aortic root, and red flow over here should not occur, but it is occurring because there is a ventricular septal defect in the perimembranous area over here. And so you can see the left to right shunt across this ventricular septal defect. And here is the pulmonary artery, and you can see in diastole here that there is flow coming towards the pulmonary artery in diastole, and this is related to in a premature infant to the presence of an arterial duct, which is patent and shunting and bouncing off the pulmonary valve in diastole. So what happened, ATL said, well, this is too expensive and we can't really see a use. So they abandoned this technique. And here again is Santayama showing us the features and failures in this condition. So in the 80s, we started looking at the development of ultrasound in the fetus. We could now measure cardiac output or flow across the valves. We could see the difference between tricuspid and mitral velocity. We could quantitate cardiac output in conditions like sacrococcygeal teratoma. Here's a patient who had progressive increase of the flow across the heart in the sacrococcygeal teratoma. The limits are really way down here. And a patient underwent surgery and the cardiac output increased, the descending aortic velocity increased, and the cardiac output fell towards normal limits. Unfortunately, the patient was delivered at 26 weeks. And here you can see, again, in a patient, a fetus with congenital aortic stenosis in the fetus, you can see the high velocity related to the stenosis of this valve. And then in 1987, a Japanese gentleman working with Aloka made the color Doppler system that ATL had abandoned and phased it onto a two-dimensional image so you could see flow coming into the ventricle and going out, and they put this on their cover. And we could do this again even in the fetus and see in a patient with aortic insufficiency the leak of the aortic valve back into the left ventricle. The next development, most important, was transesophageal echo. And this was a technique of it mounted on a gastroscope, firstly a single transducer, and then biplane and now multiple plane transducers allowed us to look at the heart in various areas. And they were made for pediatrics, so they are small at 6.8 centimeters, could be passed successfully in a 3-kilogram infant, and the adult probes. And even again, looking at what Dr. Klaus Baum had done, we're able to mount a transducer on a catheter of 5 French or 8 French type, but so very small, that could be introduced directly into the heart. So let me show you Dr. Leon Frazen, who started this technique with M-mode. And you see in the late 1970s, he developed the technique for adults who were too big to allow nice contact from the chest wall. Don't do this if you've had breakfast. So you'll see Dr. Frazen on himself volunteering for this technique. He has a small gag right over there. And then I'll show you what the technique looked like. He's holding, excuse me, he's holding the probe in place. And this is what we saw in this period of time. So you can see the dramatic, this is his aortic valve, by the way, that is promoted. And now he withdraws the probe. Again, no breakfast at this stage. So what Dr. Braunwald had said in 1990 was transesophageal echocardiography can be regarded as one of the most important investigations since the heart-lung machine. And Peter Hanrath in Germany and Klaus Baum in the Netherlands, in Delft, and Dr. Nelson Schiller in San Francisco were working on this in the 1980s, in 1982 and 83. But it never really took off until they applied color Doppler to this. And so that's when that became part of the standard for ultrasound care. Now, Dr. van Raam again decided that instead of looking at just one plane, he would develop a system that allowed 3-dimensional imaging of the heart. And rather than bore you with what a heart looks like at this stage, let me rather show you a surface rendition of a fetus. And here is a beautifully normal fetal face with a nice nasal bridge, no cleft lip, and no micrognathia, and with normal fingers and toes. And here is such an ultrasound study. This is the mitral valve looking from above. So this is the left atrial appendage. Here is the aortic root. The atrium has been removed, so you can look at the anterior mitral valve leaflet and the posterior mitral valve leaflet. And this is the quality of the imaging that we can have and the many things we can find abnormal. Here is the aortic root with the mitral valve here focused on a different area. Here are the coronary orifices, and here you can see this valve is not closing completely in this three-dimensional picture. So it provided us with fantastic imaging, which is then subsequently looked at with an atrial septal defect. Here is, we're looking at the atrium from the right side. Here's superior and inferior vena cava. And here is this fairly circular defect. And now we can look at it from the left side as well, showing the same lesion. And here is a catheter being placed across the atrial septal defect. And here is a device being opened in the left atrial aspect of this disease and applied to the septum. And of course, then closing the atrial septal defect. We can use this even in fetuses. And here we can look at a heart taken in one plane where we take 8 particular pictures and we look at the aortic arch in another plane, and we see that in this region here, there is a narrowing of the aortic arch related to a coarctation, and we can, by manipulating that, taking that out in different directions, and we can look at this in 3 dimensions any way we like. And you can see here, when we look at the whole thing, that clearly there's an area of coarctation. Maybe I should put it round so it looks like we normally look at this over here. And here's the aorta, innominate, carotid, and other carotid vessel, subclavian vessel, I beg your pardon, with an area of coarctation opposite the ductus arteriosus. And we can look to see here an anomaly associated with other cardiac anomalies, a single umbilical artery. The other umbilical artery is missing. Single left artery. And even here, this is a fetus with anomalous pulmonary venous return. And you can see here's the heart, and here are the pulmonary veins. This is courtesy of Dr. Wes Lee from Texas now, showing the vessels. And here you can see the radiographic image showing the total veins below the diaphragm, an echo picture as well. So really a remarkable interest in three-dimensional imaging. Now we went a little further and we started looking at these little dots that you see that make up the echo. They're called speckles, and we could track the motion of these things. And if we can track the motion, we can see the motion of the heart, how rapidly the heart is moving. We see that the heart contracts in a clockwise direction at the apex, at the base, and a counterclockwise direction at the cardiac apex. So the heart has actually got a squeezing phenomenon that occurs. And here's a cartoon to show some cardiac cells, myocytes, and what happens when they contract. So here are 2 cells contracting, and they're contracting actually simultaneously. Now, when we look at these 2 and separate them, they both contract at the same degree, but they contract at different rates. So we can work out that some of them are contracting well, and some, even though they contract completely, are contracting poorly. And then when we look at cells that are normal, abnormal, we see a normal cell contracting and a dead cell that doesn't contract with it. And here we see a normal cell contracting and a cell that actually stretches out in diastole. So we have a huge number of interesting things that we can do with this speckle tracking philosophy. And we can see the difference between coordinate and incoordinate contraction at the various levels that we look at the cardiac signal. And this eventually will become a 3-dimensional technique. And here you see the speckles and you see the heart contracting. So you see systole, diastole, early diastole, and then late diastole with a strain from atrial contraction, and so on and so forth. So this is the future. It's coming down the line, and eventually we will have 3-dimensional strain as a technique. So this is the end of the normal of the past. And I just enter this with my son, who was born in 1973, and this was the state-of-the-art ultrasound that his mother got when he was in utero. And so, you know, this is really hardly a recommendation. I mean, you can see the thorax and the head, and this is what you can see here. And we could see that the fetus was of good size, so that was really pretty much okay. But then this is my grandson, who was born in 2008, and this is his skull here, which isn't terribly interesting, but you can see how much better it is than here. You can see the ventricles laterally and so on and so forth. And then we looked at his heart. And here again, you can see the 4 chambers, the pulmonary veins draining into the left atrium, the left ventricle contracting normally, the right ventricle contracting normally. And then you see the long axis with the aorta coming out of the left ventricle. And you see we just expanded the scale. And look at the quality of that resolution. Anterior placenta, umbilical cord, as we see here. And now we're looking at the pulmonary artery bifurcation. And you see that coming from the ventricle and it crosses the aortic root. So an entirely normal heart. So you can see that we've come a very, very long way in ultrasound in a very short time. But what of the future? Well, Mort Saul said, we could tell the future, it lies ahead. And so I'll just show you a few things about this in the future. And this is a 3-dimensional computational model of an aortic root shown in its long axis with the aorta here, and the short axis showing the valves. And with the use of computer technology and artificial intelligence, we can make a picture showing the aortic valve leaflets, the position of the noduli of TEE as they situated on there, and the mesh-like aortic valve. And we can actually advance that even further and look at that and see the coronary arteries as they come off this structure, as well as the atrial septum and the tricuspid valve down below. We can fuse this with the X-ray PEC techniques. So here we're looking at somebody closing a defect. Here's the atrial septal defect in 3-dimensional and obtained by the echo. We can do this as well with MRI. Here's an MRI in the background with a fused picture of the mitral valve opening and closing on this picture. It's supplied to me by Dr. John Simpson from Evelina Children's Hospital. And this one from Satoshi Yasukochi, showing what we can now do with 3D flow. This is an example of 3-dimensional flow imaging. And you see the flow coming in and out here in a normal heart. And here you can see the pattern of this, or whether this is normal or abnormal, together with the ability to calculate the volume of these ventricular things. So this is the future coming down the pike for these particular issues. We can also look at things which are now expanded into other issues. We can look at shear wave elastography, which uses an ultrasound type of technique and looks at the rate of the shear wave for telling how elastic or non-elastic the tumors are. And here is a benign tumor, and here is a malignant tumor with increased elasticity. And the whole issue of ultrasound will be changing from using barium titanate crystals to using microchips when we can ever get them manufactured. And here you can see how we push this breadth of the shear wave through here and can measure the tissue. And this is done by a group in Paris, showing the elastography of the heart to tell whether the cardiac muscle is functioning normally or not. And we can put a number on the cardiac performance, etc. So really great stuff. And in addition with this, we can use, look, here's a picture of the left ventricle, but here are we looking at the microcirculation. And here you can see the capillary flow within the left ventricle to show flow coming in red and going out in blue. So a remarkable change in the kind of signals that are coming down for us in terms of three-dimensional echo. Now, I've already talked about the ultrasound, but certainly as far as early ultrasound using vaginal ultrasound is certainly a picture of remarkable facility. And here is a 12-week fetus with a vaginal ultrasound picture. And again, I think you can see everything, but when you add the color flow, the whole thing becomes a much more reasonable and understandable series of imaging. And now this use of this technique has been used with therapeutics. And here's Dr. Michael Harrison, the founder of fetal surgery, Dr. Frank Hanley and Mohan Reddy, my colleagues who did the first fetal cardiac performance. Here is the cardiac pump that they formed. This is a kind of a fish tank cardiac pump, which has been modified so that there's no dead space. And the operation, unfortunately, worked well, but the patient succumbed after the procedure. And this is Dr. Thomas Cole, a former fellow, now gynecologist, who does fetal cardiac procedures. And here in a sheep, he's putting a transesophageal catheter in to record the cardiac ultrasound so that he can look at this while he's doing balloon valvuloplasty. And then the greatest scientific journal in this country, the New York Times, in February 25, 2002, Dr. Wayne Turetsky published this business about doing a balloon valvuloplasty in a fetus with aortic stenosis. And here is such an example of that on a cartoon. Here is the needle, the catheter, and the balloon blowing up across the valve. And here comes through the mother's abdomen and uterus, through the cavity, through the chest wall, and into the left ventricle, a catheter and a balloon is inflated across the aortic valve with successful repair. I would be remiss to not mention three-dimensional printing, and here is a beautiful example of a three-dimensional print of a patient with an AV canal, showing the common AV canal straddling both of the underlying ventricles, from John Simpson in London. And this has been modified by Dr. Jeffrey Jacobs. And here is a way of teaching the surgeons how to rehearse their system. Here he's sewing a patch on the right ventricular outflow tract of a patient who's had a tetralogy repair. And you can see that a perfect rehearsal of the procedure can be done using a modeling technique. And now let me show you how to not use a modeling technique. This is a three-dimensional holography produced in Israel. And here is the so-called system with the heart shown above the system. I'll just go a little bit further to show you can rotate it around. You can slice and dice the heart any way you want. But let me go back to the fetus again and show you a mother who's just had a fetal ultrasound study and a three-dimensional recognition of her own fetus. And here you see the fetus rotating around. It's a boy at 12 weeks of age. And you can measure various things like the fetal length, just for example. And then when you switch off the machine, the image disappears. So where have we come from? Well, we come down to POCUS, which is where I began and where I'll probably end. And here is the development of the ultrasound transducers and machines. And here you see they get smaller and smaller until you can hold it in your hand and buy this system for a mere $200 a month rent and see not only cardiac ultrasound, but all other ultrasound, making the need for a stethoscope for when the power goes out. And then, of course, we have to think of the new and exciting development of artificial intelligence, which is no match for natural stupidity. But anyway, artificial intelligence and machine learning are now becoming into prominence, and there are things that machines can recognize that the human eye and the human brain are not capable of recognizing. And if the machine can beat the world chess champion, it's quite clear that machines have certain advantages over humans, which are going to create a great application in the future. And so what we have to do in conclusion is use Roberta Williams's analogy that ultrasound and echocardiography have moved forward by collaboration and by exchange of ideas between Europe, Africa, Asia, Australia, and the Americas. And the field of echocardiography, being predominantly visual in nature, has spurred international meetings and disciplines that created a global community and promoted the exchange of information about cardiology as well as imaging as a whole. And therefore, echocardiography is to cardiology what the internet is to communication. Thank you very much.
That was amazing.